Hello and welcome to another intensive care hotline and intensivecareathome.com emergency question and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm the host of the show. What makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? I'm a critical care nurse by background. I have worked in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care, and where I've been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com. And we have saved many lives with our consulting and advocacy. And you can verify that if you go to intensivecarehotline.com and you click on our testimonials section, or you go to our podcast section at intensivecarehotline.com and you listen to some client interviews. I am also the founder and managing director of Intensive Care at Home, where we send critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, but also for otherwise medically complex adults and children on home BiPAP, home CPAP, home tracheostomy care when clients are not ventilated, but also for home TPN or any other medical complexities. With Intensive Care at Home, we are currently operating all around Australia and in all major capital cities as well as regional and rural areas. With Intensive Care at Home, we are NDIS approved, TAC in Victoria, WorkSafe in Victoria, NIISQ in Queensland, as well as iCare in New South Wales. Our clients have also received funding through public hospitals, private health funds, as well as departments of health. Now, I also want to welcome our viewers that watch this on replay. And you can ask as many questions as you like. You can join me live on the show here, and you can talk to me directly, and I'll post the StreamYard link into the chat pad. You can join me live on the show here by clicking on the link, or you can type your questions into the chat pad. Alternatively, I just start reading out questions that have come this week during via email, and I will read them out to you, and in the meantime just type your questions into the chat pad and you can go from there. Now, first question today is coming from Leonie, who says, "Hi Patrick, my mom is in LTAC with a tracheostomy and she's making minimal mobility progress in LTAC, and she's having some tracheostomy issues. It can't be removed." Now, first things first, I've been talking about LTACs here for over a decade, about LTACs in the US, and our advice is not to go to LTACs. That is our advice, and I stand by this. I've done a video recently about the 10 reasons why you shouldn't go to LTAC. And I believe that video still stands the test of time, that if you have a loved one critically ill in intensive care in the US, because LTACs are unique to the US, that you shouldn't go to LTAC, full stop. And if ICUs tell you, oh, that is the only option, they are lying to you. They're not being truthful. We've helped countless families with our advocacy to stay in ICU instead of going to LTAC. And they always thanked us for it because, things in ICU have improved for them. But the families that have gone to LTAC, things have gone from bad to worse, right? So therefore, I'm not surprised when Leonie says there is minimal mobility and minimal rehabilitation in LTAC, because when you look at LTAC's websites, for example, they promise you that they're the experts on ventilation, meaning they're the experts on rehabilitation, they're the experts on physiotherapy and all of that. And then when patients do go to LTAC, none of it is going to happen. Patients literally wither away in their beds. Critically ill patients go from ICU, where they have 1-to-1, 1-to-2 nurse-to-patient ratio, ICU doctors, respiratory therapists. They go to LTAC, where they have a 1-to-4, 1-to-6, 1-to-8, sometimes 1-to-10 nurse-to-patient ratios, without ventilator competent nurses, without doctors on site. It is a disaster, and I'm happy to be challenged on what I'm saying here, but no one has challenged me on it yet. If anything, I had comments from YouTube viewers or on our website, even from nurses themselves that have worked in LTAC and critical care, basically confirming everything that I'm saying here. So, Leonie, you got to get out of LTAC. You should have never agreed to going there in the first place, right? And you shouldn't agree going there. You got to get your mom out of there, because it is not a good place. Right? It is not a good place, and no matter what they're telling you, it's bait and switch. It is bait and switch, no more than that. Another thing that we've seen over and over again is that when patients do go from ICU to LTAC, they're bouncing back to ICU in no time, and that should be of massive concern for you, because what we've seen over and over again is patients go from ICU to LTAC, and then within 24, 48, not even 72 hours, they're bouncing back into ICU, and then they're bouncing back into another ICU where they originally came from. Basically moving a patient from place to place to place within 72 hours. A patient that's critically ill, that is madness. It is negligent, right? A critically ill patient needs stability, needs a stable team around them. They don't need to be moved from place to place while they're critically ill, right? I hope that makes sense, actually, for anyone watching this, that I'm not talking nonsense here. I think I am speaking a lot of common sense here, right? But common sense is no more all that common, or is it, right? You can't move a critically ill patient from place to place. Okay, so next question is coming from Terrell, but before I go to Terrell's question, please type your questions into the chat pad, or join me live on the stream here. I posted the StreamYard link in there. You can join me live on the show here and ask me questions here live. That way I can really dive deep into whatever it is that you need answered. Don't be shy. I don't bite. Okay, question from Terrell. Hi, Patrick. My dad had a cardiac arrest and no oxygen to the brain for 8 minutes. Once he got to the ICU, his body was cooled for 48 hours and an MRI scan of the brain was done, where it showed he has brain damage. He has also developed seizures which are not under control. He was taken off the ventilator and has an oxygen tube in his nose. He has not answered commands or completely woken up. He also has pneumonia. It has been 8 days now. Is there anything as a family we should be asking the doctors and neurology doctors about getting the seizures under control? Or should we still give it time? Well, Terrell, that's actually good news that your dad is off the ventilator already. And I'm surprised they've done that, given that he hasn't answered any commands. That's quite unusual. But obviously he must be breathing by himself. They must be thinking he can manage and protect his own airway, right? Because if he couldn't, they probably wouldn't have taken him off the ventilator, right? Unless they've extubated him. Extubation means the removal of the breathing tube to move him towards end of life. Is that the case? Have they moved him to hospice, right? So that is a question that I have for you, because like I said, my experience in nearly 25 years critical care is that patients won't be extubated unless they can manage and protect their own airway. If he's not obeying commands, if he's not awake, if he has seizures, there's a high chance he can't protect his own airway, right? So that leads me to what questions should you be asking, right? Why do they think they can't control the seizures? That's number one. What medications is he getting to control the seizures? Right? That would be one of my questions. What are they doing to manage the seizures? Right? And you are saying he's got an oxygen tube in his nose. Okay, he needs some oxygen still. That's fair enough. And is he at risk of not being able to protect his airway, i.e., is he at risk of aspiration? For example, if he's not awake, can he swallow? Right? And if he can't swallow properly, that means sputum will go down into his lungs and not into the stomach, potentially causing an aspiration pneumonia. Right? And if he has a pneumonia, how are they treating the pneumonia? And does he need to go back on the ventilator to treat the pneumonia? Does he have a pneumonia because he can't swallow and he has already aspirated? Right? So that is a question that you should be asking. It's been 8 days now. It's probably not a long time in the bigger scheme of things. I mean, he had no oxygen to the brain for 8 minutes. That is a long time, and that might have caused significant brain damage. Do you just want to give up after 8 days? I don't know. These are questions that we need to ask here. How do you get the seizures under control? Is he on anti-seizure medications? If yes, what are they giving? And also, if the anti-seizure medications are not keeping it under control, what are they giving him on top of the anti-seizure medications? There could be some as-needed regulations, medications such as midazolam/Versed, diazepam, clobazam, and other anti-seizure medications that can be used in an acute phase. And here's another risk. If he, let's just say, during a global or a tonic-clonic seizure, let's just say he starts vomiting, if he can't protect his airway, once again, he is at risk of an aspiration pneumonia. And given that he's got a pneumonia, according to your email, are they giving him antibiotics? How are they treating it? Right? Also, after a critical illness, it is not uncommon that patients don't wake up straight away because they're simply critically ill and they are exhausted and tired. So, yes, it sounds to me like he's got an anoxic brain injury or a hypoxic brain injury, but he might just need time for now. And then you can determine what's going to happen from there. I know 8 days, you're saying it's been 8 days. I know it feels like an eternity for you, but it is not a long time in the bigger scheme of things. Keep that in mind, please. Okay, I hope that answers your question, Terrell. If you have a question that you want to ask here, type them into the chat pad. Or join me live on the stream here by clicking on the StreamYard link and ask me a question live on the show. Also, if you like my videos, I encourage you to subscribe to my YouTube channel, to click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have, and please share the video with your friends and families who have family members in intensive care. The more people we can help, the better. Now, let's move on to the next question from Jonathan, who says, he's talking about induced comas in general, and he says, it's actually pretty common for the night terrors. Do you continue to have any of those dreams? Again, that's a comment on my YouTube channel for someone who has been in an induced coma. Do you continue to have any of those nightmares? Again, do you have any of that were the exact opposite of horrific? I still can remember what it feels like every dream in order, as I'm calling on memories, not dreams. I know 3 months was long enough to change who I am on every level on my being. Religion, philosophy, perspective, consciousness, I could go on. Do you ever have triggers or anxiety or depression related to specific dreams that feel as if pure human emotion, or not like a dream, but another time in which you lived and existed with another completely complex life and family? Sorry for all the crazy questions, just kind of running off my feelings. Thank you, Jonathan, for sharing that. And I think it is really important that, people understand what can be the side effects of an induced coma, and that is obviously a survivor of intensive care, Jonathan, who explains that to everyone on YouTube Live. So that is really good. And thank you for sharing. A lot of ex-ICU patients and survivors need that TLC, and need extra care, need time to rest and heal, when they've come out of an induced coma. It can be a very traumatic experience, and patients can report post-traumatic stress, unfortunately. Next question from Carl, who says, "Hi, Patrick. My wife will not wake up after surgery after many days. What should I do?" Thank you, Carl, for the question. And I'm so sorry to hear about your wife not waking up after a few days after surgery. Now, here's the thing. A lot of it depends here. Okay, what type of surgery has it been? Is it related to a brain injury? Is the surgery related to the brain? Was it open heart surgery? Was it a hip replacement? Was it abdominal surgery? You are not specific what type of surgery it is. But let's just say it is not related to the brain, and let's just say it has been anything: open heart surgery, hip replacement, abdominal surgery, who knows what, like maybe a removal of the thyroid, the list goes on. The first thing is, has sedation been off? And Jacqueline, I can see you. I'll let you in 1 second. Has sedation been off? And have they done a CT scan of the brain, MRI scan of the brain? Have they done the neuro testing that there hasn't been a stroke or anything else that is going to be important? Hi, Jacqueline. Nice to meet you. You are on mute.
Oh, hi, how are you doing?
I'm really well, thank you. How are you?
I'm fine. I have a question for you.
Please.
My father, 87 years old, was found unresponsive in the hospital. They had him for observation. He had a cardiac arrest. Um, they revived him, worked on him for 40 minutes. This happened May 25th. They ended up doing a tracheotomy. He's in LTAC now, but he's doing. He's off of the major ventilator, and they are doing physical therapy with him at LTAC, and but he just hasn't woken up. He's responsive to our voices and music and things like that, but he just hasn't. He's not squeezing our hands anymore. Initially, he was, but he's not doing that now. And basically, I want to bring him home. He's a military vet, so I want to bring him home and um, just trying to make some decisions of, basically, is that a good ideal to do, or should he go into rehab some more, or
Yeah. Jacqueline, are they sort of counting down in terms of, are they telling you he needs to leave LTAC in X number of days?
oh, no, he's been there a week now. He was at in ICU for a month. So he's been at LTAC for a week now.
See, so it's early
Uh,
days.
He is real early.
Okay. And are you happy with the level of care he's getting so far?
Yes, so far they went. Yeah, I went yesterday, and he's sitting. They had him sitting up in the chair, and they move, they turn him, and yeah, yeah. So they're so far. I
Okay.
have no
So,
complaints with. I know you in LTAC, but so far
Look,
I'm really surprised. They're doing pretty good.
look, look, Jacqueline. I want to know if there's a good LTAC, because if there is a good LTAC, I will make recommendations. I just
Oh,
haven't seen it. I just haven't seen
uh-huh,
it. Like if there is a good LTAC, I will tell people about it just as much as I
uh-huh.
tell people about it if LTACs are not good.
Well,
It's,
I'm in Georgia, so it's part of Emory University, one of the major hospitals here in Georgia,
right.
and so far I have no complaints. We have no complaints. They're doing physical therapy and they're speaking, and they're telling us that we need to, we to maybe he, as far as family, he would react more, and he seems to react more with family. So,
Of course, of course.
mhm.
Okay, okay, that's really good. So, when you say he's had CPR for 40 minutes, obviously he had some. Uh, there is some brain injury from that.
Yes, they're saying like that frontal area is pretty much really severely damaged.
Damaged. Okay, okay.
Hmm.
And when you ask him to squeeze your hands, does he squeeze your hands?
No, not now. Before, um, he had the tracheotomy and everything, ostomy. He was squeezing our hands. But now I see more or less his eyes. His eyes are moving, and facial expressions.
But you are more or less saying that his cognition isn't as good as it was a few days, weeks ago.
Right. It's different
Okay.
because he was able to squeeze our hands
Yes.
before.
And any ideas what might have changed?
No ideals.
Okay. Do you know what medications he's on?
They have him on what regular, like his blood pressure medications. They stopped the seizure medications. Um, he was on that for maybe like 2 weeks initially, but he's not having any seizures anymore.
Okay, good.
Um, just his regular basic medications. Um, yeah, nothing for seizures. He's not. Yeah.
Okay. But he stopped having seizures.
No, he's not having seizures at all.
Good, good. Okay.
Hmm. Hmm.
Do do they have an answer why he might have stopped obeying commands or following instructions? Have they got an answer for that?
They have said because of the damage there in the frontal brain area. That's
Okay.
what that's what they have said.
Right.
But they are still working on getting him to respond.
Okay. Okay. When he's getting out of bed, is his cognition better?
Yes, I did notice yesterday, when they were shifting him, um, his eyes open almost as though he was mad, like, what are y'all doing to me? His facial expression and his eyes. So I they stayed open for like about 5 minutes, and I was able to. It seems as though he recognized me, so I just talked, about daily things and what's been going on in the world, and he seemed to recognize me. So, and it was
Okay.
about 5 minutes,
Okay. Great.
and then he just closed his eyes and I guess went back to his world.
Right. Right. Okay.
Hmm.
How far away is he from having the tracheostomy removed? Are they talking about that?
Uh, they have put the, let's see, what do they call it? It's like the bubble um part of the trach. It's different weaning steps. They've taken him off the big machine.
Yeah.
And now he's just on the oxygen is just blowing into it.
Yeah.
And they're looking at possibly maybe capping it maybe in 2 weeks if he continues to do well.
Okay.
Because he's breathing, basically breathing on his own.
Yeah. But
Hmm.
but he is already breathing on his own. If
Right.
they've
He is
got it.
breathing. Mhm.
So okay. So to come back, I haven't forgotten about your original question whether you can take him home or not. I haven't forgotten about that.
Okay. Okay.
I just try to get as much information as possible. So Jacqueline, here's the thing. Taking him home without a tracheostomy will be so much easier for you.
Hmm.
Taking him home with a tracheostomy will be very difficult for you without having 24-hour and around the clock nursing care with someone that's tracheostomy competent. The risk,
Okay.
from my extensive experience, is too high. Now,
Hmm.
I would argue that your best case scenario here is to have them remove the trach, ideally, and it might take them another couple of weeks. But if that can be achieved, your life, half of your problems will be gone, because if they can
Hmm.
remove it, he can manage his own airway,
Okay.
right?
Right.
Whereas with a tracheostomy, someone needs to manage the airway,
Hmm.
right? And you constantly have to monitor the trach. You have to monitor for blockages. You might have to suction him. You know, do you know if he's got an inner tube, an inner cannula?
No, they've actually taken that out
Okay.
because we're just doing the regular suction from the inside of the mouth.
Okay. So they're not suctioning him through the tracheostomy tube.
No, no.
Are you sure?
When I was there yesterday, let's see. Yes, they are. They are. Excuse. Yes, they are. They are.
Right.
Yeah, I try not to look. I think sometimes,
It's a
but they
okay.
are because because they took because they cleaned around the area and yeah, they are. Hmm.
Okay. Okay. Well, let's just quickly talk through, Jacqueline, what needs to happen, to have the tracheostomy removed.
Hmm.
The first thing that needs to happen is minimal suctioning, right?
Okay.
So he needs to be able to clear his own airway. He needs to have a good strong cough.
Okay. He's been coughing. Hmm.
Okay, great, great. Okay. Um, because you got to picture this: once the tracheostomy is out, he needs to be able to bring up his own secretions. Because
Correct. Hmm.
if he can't bring up his own secretions, they will need to continue suctioning him,
Okay.
right? So that's
Right.
number one. Number two, have they done a swallow assessment?
Yes, they did attempt that with the ice chip.
Okay, okay,
And that was last week, and he didn't swallow. That was last week, but this week, I don't think they tried it this week.
okay. When you
Hmm.
say he didn't swallow, they put an ice chip in his mouth and he was coughing.
Well, no, they put an ice chip in to see if he would swallow when it melted in his mouth.
Yep, yep. And what
Hmm.
what did he do? Did you see it yourself?
No, I didn't see it myself,
Okay,
but that he didn't swallow
swallow. Okay,
that time. So they
okay,
haven't tried it again as of yet.
okay. All right. So number one, he needs to cough, needs to protect his own airway. Number two, he needs to be able to swallow.
Okay.
Right. Number three, they tried a speaking valve.
No, the speaking valve.
Do you know what I'm
Mm,
talking about there?
no.
Okay.
Mhm.
So for patients with a tracheostomy,
Mhm.
eventually they should try a speaking valve
Okay.
to see if he can talk. Right?
Okay.
Is he trying to talk?
I see more facial expressions and his mouth moving, so it's possible he's trying to talk.
Okay.
So I never
Okay.
thought about that. So okay, if he was trying to speak, we wouldn't be able to hear it because of the
The vocal cords would be paralyzed at the moment
okay.
because of the tube. However,
Yeah. Hmm.
do you know if he has the balloon up? Do you know what I mean? The tracheostomy cuff. Do you know what I'm talking about?
Is that there's like a little blue thing that hangs out from
Yep.
yes. Okay.
And in that little blue thing,
Hmm.
they would be injecting a few mils of air to block the tracheostomy in the back of the throat.
Okay.
Now, if you give me 1 second, I'll get
Okay.
a tracheostomy and I'll show it to you here. Just give me 1 second, please.
Okay. Thank
I
you.
I will show it to you here so you can actually understand what I'm talking about, because these are all important things for you to understand what needs to happen to have the tracheostomy removed. Now, just give me 1 second. So, can you see that?
Yes.
So that's a tracheostomy tube, obviously.
Hmm.
At, so, hang on, I'll just show you so that you can see what's happening here. So you can see that little, hang on, there we go. Can you see
That's
now?
it.
Now I'm injecting air. Can you see that balloon going up?
Yes.
So if that balloon is up, right, most
Okay.
likely your dad can't swallow, most
Okay.
likely, because that balloon stops saliva from going into the lungs,
Okay.
right? So you should check with them if he's got a tracheostomy with that balloon.
Hmm.
I'd say most likely he does.
Okay.
On some occasions, patients might have a tracheostomy without a balloon, but that's very rare. It's really
Hmm.
only for patients that only need the tracheostomy for suctioning. They can swallow, but they need the tracheostomy for suctioning because they can't bring up their secretions,
Hmm.
right? I argue with knowing what you've shared about your dad, I argue he does have a blocked tracheostomy, most likely.
Probably more than likely. Hmm.
So, what they need to do as a next step, they should be taking the balloon down, right? Put
Hmm.
up a put up a speaking valve. The speaking valve won't work without the balloon down because the balloon is basically what paralyzes the vocal cords,
The vocal cords. Okay. Okay.
right?
Thank you for that. Okay.
So then, okay, let's just keep moving. What, like in terms of when to take out the tracheostomy. He needs to cough. He needs to be able to swallow. The balloon
Hmm.
needs to be down. It would be good if he can talk. It's not necessarily a prerequisite that people need to talk in order to take the tracheostomy tube out, but it would help, of course.
Okay.
Once all of that is done, then they should cap the tracheostomy,
Hmm.
right? So capping the tracheostomy means, again, I can show you that here if you give me another second. Uh, so this, hang on. Oh, hang on. What have I done now? Yeah, hang on. So this is the front of a tracheostomy. I think you can see that.
Yeah. I see it. Mhm.
So when they're capping it, they put in like a little guide wire, and then they block it like this. Can you see that? So
Yes.
I
Yes.
put the block in, and then once the block is in, he should be able to breathe either through the nose or the mouth.
Mouth. Okay.
right?
Okay.
And
Thank you.
if he ticks all of those boxes, right,
Mm-hmm.
they should be able to take the tracheostomy tube out.
Okay. Okay.
Okay,
Thank you. Thank you.
you're welcome. You're welcome. So it's a really, you know, and then to answer your question, can you take him home? Like I said, I would not take your dad home without having 24-hour nursing care with a tracheostomy.
With the trachea. Okay.
If he has the tracheostomy removed, he probably still needs some care,
Mm-hmm. Mm-hmm.
but the airway is most vulnerable with a tracheostomy.
Okay.
If that tracheostomy blocks at home and you don't know what to
To
do,
do.
you basically have 3 minutes to protect
Just
that airway,
mm-hmm. Okay.
right?
Okay.
So
Yes. True.
so your best way forward here, I believe, with what you've shared with me, is to ask them to move him towards a tracheostomy decannulation as quickly as possible.
Correct. And that's something. Me and my brothers were talking about. Yeah, that would be the best scenario to have that completely blocked for him. Yeah.
Completely removed. Completely
Hmm.
removed.
Completely removed.
You know, then you don't need to worry about the airway,
Hmm.
right?
Right.
Um, he does have a peg tube.
Yes, he does have the peg tube. Yes. Hmm.
Okay. So then you wouldn't have to worry, at least in the beginning, you wouldn't have to worry about feeding him. You can just use the peg tube.
Hmm.
Again, ideally, once the tracheostomy tube is out and hopefully he can swallow, ideally you can get him back to eat and drink, but they need to do the swallow test while he's
First,
in hospital,
while it's in. Hmm.
right?
Right.
And then go from there. Now, when he's getting out of bed, are they using a lifting machine or what are they doing?
Yes, they're using it. Is it pronounced the Hoyt lift? HOY
Yeah, yeah,
something.
the Hoyer lift. Yep.
Hoya
Right.
lift. Yes. Yes, that's what they're using.
Okay. You will probably need similar devices at home, whether he has a tracheostomy or he doesn't.
Hmm. Okay.
Because you don't want to, if you do it yourself or your family, or even if you employ people, even if you have home health care coming in, you don't want people to end up
To
with a back
back
injury.
problem. Right. 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 Okay. I thank you so much for speaking with me and helping me figure out this situation.
It's a great pleasure. And just anticipating what's going to come, because I've seen it so many times, Jacqueline.
Hmm.
I anticipate, if things are not moving as quickly as you would like, as they would like, usually when it comes to the day 30 mark in
Hmm.
LTAC, they want to send him to a SNF, to a skilled nursing facility.
Right.
I can almost anticipate that. Now, if he is making progress and if he's making strides to moving away from the tracheostomy, and hopefully they can decannulate him, I wouldn't go anywhere until you have the tracheostomy removed, and then you can hopefully take him home,
Right. Right. That. Yeah.
right?
That's
Because
correct.
because if he does end up going to a skilled nursing facility, the level of care there is even
It's,
worse.
yes,
And
it is.
I am pleased to hear that you have found a good LTAC. I'm very pleased. I'm very pleased that if they can take the tracheostomy out and they can
Uh-huh.
take it, that would be amazing.
Yes, yes, yes. That's one of the reason I actually researched myself and pushed for them to send him to this particular place actually because they were trying to send him hours away and I'm that. Like that doesn't make any sense to send a patient hours away from family.
It doesn't. It doesn't, does
Yeah,
it?
yeah. So,
So
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 it's
the
uh
the LTAC is close to home.
yes, it's just 30 minutes from where I
Yeah,
am. So yeah, so it's very convenient. I can pop up anytime.
that's good. Yeah, no, that is
hmm
very important.
hmm
That is very important. I
It
mean,
is
if you
very important.
can't be around,
All right, and it's good to when you have a loved one in a situation where someone else is taking care of them. It's good to be able to pop up without anyone knowing when you're coming, just to make sure
absolutely. Yes,
things are flowing like they should.
keep them on their toes. Good
Yes, yes.
good
Well,
idea.
thank you.
It's a
I know
pleasure.
there are other
All the
people that want to talk to you, but I thank you so much.
It's a great pleasure. Nice to talk to you, Jacqueline. Take
Nice
care.
to talk to you. Thank you. You too.
Thank you. Bye. All right. Who wants to join in next? Or you can type your questions into the chat pad. If not, I have emails sitting in my inbox that I can answer. But you're welcome to join me. Um, just use the StreamYard link here in the chat pad, or type your questions into the chat pad. I will go on to the next question. The question comes from Barlow, who says, what should I include in a medical power of attorney statement for my family? Well, that is a very good question. And it's, Barlow, you are obviously thinking ahead here. Most families don't, unfortunately. Well, you should include in a medical power of attorney for your family whatever you think you want in a situation when, if you need to go to intensive care, or if you can't make decisions for yourself. So, you shouldn't be limiting that to anything. You should be putting down there what you want, So I'll give you an example. How many families in intensive care are grappling with the fact, what would my loved one want? Most of the time they say, well, they want everything to be done. But at the end of the day, some patients might say, I don't want everything to be done. I don't want to be staying on a ventilator with a tracheostomy. That's not what I want. I'd rather be dead. And that's fine too. So really, it's not limited to anything that, that you want or don't want. It is really up to you. Do your research, which it sounds to me like you are. And that's what it comes down to. But be very clear in your power of attorney statement what you want. Do your research. Don't be limited by anything. Or limit yourself if you want to. If you say, hey, if I'm in ICU for 2 weeks, 3 weeks, and there's no progress, then I want, I want end of life care. I want palliative care. It's not, it's not a judgment call for anyone, but for you. This is your life, and you need to think about what you want in a power of attorney statement. It really all comes down to you. Also, speak maybe to your family doctor, to your GP, speak to maybe an attorney as well, to a lawyer or an attorney. What they advise, is in there. But you need to write in there what you want. That's what it comes down to, right? And you should also keep in mind that most ICUs are rushing to end the life. You can see that if you've done enough research, and you can see what content that we are putting out there, which is real content from real people. You probably know that many ICUs are rushing towards end of life because they often need beds. They want to save money. You have to keep that in mind when you do your power of attorney statement. Right, Colin has a question. What's this about again? Colin, I am answering questions here for families in intensive care or with intensive care at home. That's what this show is all about. If you have a loved one in intensive care, type your questions into the chat pad here, or join me live on the show here with the StreamYard link. Before I spoke to Jacqueline, I had a question from a reader. I think it was that their spouse is not waking up from an induced coma. And I've got another similar question here from Rebecca, who says, "Hi, Patrick, my dad is not waking up from the induced coma." Again, this is a very regular question we're getting here. And what should you do if your loved one is not waking up from an induced coma? The first distinction that I need to make here is if A, there is a brain injury leading up to it, or there is no brain injury leading up to it, you know. So, for example, many families in intensive care or many patients in intensive care don't wake up after an induced coma if they have a brain injury, an anoxic brain injury, hypoxic brain injury, traumatic brain injury. Maybe they've had a brain aneurysm, maybe they've got a brain tumor, you know, and they're not waking up. However, there are also many patients in intensive care that also don't wake up after an induced coma if they don't have a brain injury. So it's really not a one size fits all. It really comes down to you know, what medicines your loved one had while they were in an induced coma. Also, were they paralyzed? And what I mean with paralyzed, were they paralyzed with medications, paralyzing agents? Were they used? Were they, for example, in prone position, right? Did they have, because when someone is in prone position in intensive care, they need often, you know, for lack of a better term, truckloads of sedation and opiates because it's very uncomfortable and that takes longer for patients to wake up. Whereas if they have only been mildly sedated during an induced coma, it should, in theory, it should help them to wake up quicker, right? Other things that you need to look at when you have a loved one in intensive care that doesn't wake up after an induced coma, are they potentially in kidney or liver failure? Because if they are in kidney or liver failure, what happens is the medications that are given for sedation and opiates are not washed out of the system, right? And if they're not washed out of the system, they be stored in the tissues in the body, and it takes longer for a patient to wake up as well. Next, if your loved one isn't waking up, has a neurology consult been done? Have they had an MRI scan of the brain, a CT scan of the brain to rule out a stroke, seizures, right? Has a neurological event been ruled out? Has there been a brain bleed, right? So the other thing that you have to keep in mind is that when someone is critically ill and they're off sedation, off opiates, they are critically ill. And what that means is their body might just need to rest and heal. And that could be one of the reasons why they're not waking up yet, right? So sometimes you simply have to give it time. But if it goes on for too long, you absolutely need to have a neurology consult and you absolutely need to check for a CT scan of the brain, MRI scan of the brain, and so forth. Now, also what's important when your loved one isn't waking up after an induced coma is physical therapy, physiotherapy, stimulation, right? Moving the body around, even if it's only moving the arms and the legs and the joints, you know, sitting on the edge of the bed if they're hemodynamically stable, right? Those are all important things to consider when your loved one isn't waking up after an induced coma. Other things to consider are, you know, have they had short-acting sedatives such as propofol or Precedex, or have they had long-acting sedatives such as midazolam/Versed, because midazolam or Versed is a benzodiazepine, right? And it is also addictive in nature, right? And if it's addictive, patients might also go through a withdrawal process when they're waking up, right? Also, most patients in an induced coma receive morphine or fentanyl. And with morphine or fentanyl, they are also addictive in nature and they're also literally knocking out people, right? And that might also delay waking up. And patients might also go through a withdrawal process with morphine or fentanyl or oxycodone, whatever opiates are given, right? So you have to understand the ins and outs, why your loved one isn't waking up, and you need to look at all angles. Now, if your loved one had too many or too much sedation and too much opiates, there's also the option to potentially give an antidote, such as naloxone for opiates, right? Or for um, for for midazolam, you can give the antidote of flumazenil, so that reverses the effect, and then maybe waking up can happen quicker, right? So I hope that answers that question. Now, other question from Christian, who says, "Hi Patrick, my dad was resuscitated after cardiac arrest in ICU because he had an upper GI bleed, and now he is 2 days out of sedation and his eyes are open, but he isn't moving." Okay, right. Not dissimilar to what we've had, that someone isn't waking up after an induced coma. The difference here is we have more information. So he had a cardiac arrest and he had an upper GI bleed. GI bleed means a gastrointestinal bleed, usually a bleed in the stomach or in the small bowels, in the intestines. Now, if your dad was resuscitated after cardiac arrest, the first question is, how long did it take them to resuscitate your dad? Right? Was it minutes? Was it a few minutes? Was it, more than 5 minutes, more than 10 minutes? We had someone on the call here today. I think it was Jacqueline earlier who said her dad was resuscitated for 40 minutes, right? So some of it depends on the length of time. Has there been some brain damage done? Has there been no brain damage? Has a CT scan been done of the brain? Has an MRI scan been done of the brain? Right? And those are questions that you need to consider. Now, with him being 2 days out of sedation is not a long time. Also, you haven't shared how many days ago was the cardiac arrest? How many days has your dad been intubated for? Again, what sedation has he been on? What opiates has he been on? Right? Has it been 10 days he was in an induced coma? Has it been 2 days he was in an induced coma? Has it been 2 weeks he was in an induced coma, potentially even longer? So timelines are important. Other things to consider, once again, is he in kidney failure? Is he in liver failure? Those are things that need to be considered as well. Right? And it's good that he is opening eyes, right? But he isn't moving yet. And like I said before, he might just be sick and he might just be critically ill to the point where he's just simply resting and healing. Right? So you gotta give it some time. And if time isn't improving his situation, he absolutely needs to be seen by a neurologist and needs to be assessed by a neurologist what is going on with his brain. Is he still getting rid of sedatives and opiates in the body? That could be another thing that's delaying him waking up, right? So, and then looking at kidney failure, liver failure, is all of that working? Would dialysis help, if he's in kidney failure, to wash out sedatives and opiates? That can sometimes also help with waking up after an induced coma. Generally speaking, and it is generally speaking, the older a patient, generally speaking, the longer it may take to wake up. But, I've seen older patients waking up quickly. I've seen younger patients not wake up quickly. So it isn't a one size fits all, but generally speaking, that is the case. Age might play a role as well. Okay, we are coming to the hour mark. I do need to wrap this up in a minute. I usually go for an hour. I do these YouTube lives once a week. 10:30 a.m. on a Sunday, Sydney, Melbourne time in Australia, 8:30 p.m. Eastern Standard Time in the US on a Saturday night. which is 5:30 p.m. Pacific time on a Saturday afternoon if you're on the West Coast in the US. If you like my videos here, if you like my YouTube lives, click the like button, click the notification bell, subscribe to my YouTube channel so you could get notification when my next videos are coming out and when I do the next YouTube live. And make some comments here what you want to see next, whether you want me to cover a specific topic, you know, and if you want to, you can make a small donation so we can make as many videos as possible, helping as many families in intensive care as possible. You will find us at intensivecarehotline.com. You can call us there on one of the numbers on the top of our website, or you can send us an email to support@intensivecarehotline.com. With intensive care at home, we're operating all around Australia, in all major capital cities, as well as in all regional and rural areas. If you need intensive care at home in the US or in the UK, I encourage you to reach out to us as well at Intensive Care at Home, and we can help you there privately and guide you and point you in the right direction. With Intensive Care at Home, we are NDIS accredited. We also have our own NDIS support coordinator for level 2 and level 3 NDIS support coordination. With Intensive Care Hotline, we also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. You also get exclusive access to 21 ebooks and 21 videos that I've personally written and recorded, making sure you make informed decisions, have peace of mind, control, power, and influence. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I also talk to doctors and nurses directly on your behalf. I represent you in family meetings with intensive care teams. We do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care. If you have unanswered questions, if you need closure, or if you are suspecting medical negligence. If you are looking for your hospital for emptying intensive care beds or ED bed, we are also sending our critical care nurses not only into the home to keep ICUs empty or empty ICUs, also to keep ED beds empty. We've also done an ED bypass service for the Western Sydney local area health district, so we can help your hospital as well with ED at home. Now, I want to thank you once again for watching. Spread the word, share the video, and I will see you all again during the week with my quick tip videos, or next week on another YouTube live. I wish you and your families all the best. Have a wonderful week and a wonderful weekend. Take care for now.